This lecture will be on Chapter 19, Introduction to Thrombosis and Anticoagulant Therapy. At the end of this lecture, the student will be able to define thrombophilia and thrombosis, identify hemostatic changes responsible for pathologic thrombosis, describe antithrombin, protein C, and protein S with regard to properties, mode of action, factors affected, and complications associated with their deficiencies. Identify inherited risk factors for thrombosis. List the common acquired risk factors associated with thrombosis. Describe activated protein C resistance with regard to pathophysiology, mode of action, and associated complications. Describe heparin-induced thrombocytopenia, including the cause, clinical manifestations, and pathophysiology of the disease. Identify the laboratory tests and results used for diagnosis of factor V Leiden and heparin-induced thrombocytopenia. List the types of anticoagulant drugs used for treatment of thrombotic disorders. Describe the mechanism of action of each anticoagulant drug commonly used for treatment of thrombotic disorders. Evaluate the laboratory tests used for monitoring of heparin and warfarin therapy. Define the anti-factor 10A assay and its clinical application. Identify the alternative anticoagulant drugs and their mode of activity. Thrombophilia can be either inherited or an acquired condition that alters coagulation and predisposes an individual to thrombosis, which is clotting or clots. Thrombosis is the formation of a blood clot in the vasculature, which is your vascular system. You have two types of thrombosis. You can have arterial, meaning the clot is in an artery, or venous, meaning that the clot has formed in a vein. Arterial thrombosis, or a platelet that forms in an artery, is made up of platelets and small amounts of red blood cells and white blood cells. A venous thrombosis, or a blood clot that forms in the vein, consists of a fibrin clot and just red blood cells. Both of these can be result from some sort of vascular injury, platelet activation, coagulation activation, some sort of defect in the fibrinolytic system, or a deficiency or a defect in the physiologic coagulation inhibitors. Risk factors that are associated with thrombosis are inherited risk factors or something that has contributed to you acquiring that sort of condition. Arterial and venous thrombosis are the most common causes of death in developed countries. When it comes to arterial thrombosis, what that can be tied to is a myocardial infarction, an MI, it's also known as a heart attack, as well as it is an effect of the arterial thrombosis can also cause stroke. The physiologic thrombosis is due to the body's natural response to a vascular injury. It's normally localized and it forms to prevent any type of excess blood loss. A pathologic thrombosis is going to be caused by an inherited or an acquired condition. A DVT or deep vein thrombosis, arterial thrombosis, or a PE is going to be tied to some sort of inherited or acquired condition. Complications of an arterial thrombosis are going to be occlusions of the vascular system, meaning there's going to be a blockage that's going to affect the blood flow. Complications of a venous thrombosis is going to be a pulmonary embolism. Again, that is a blood clot that is in the lungs. Arterial thrombosis can be caused by hypertension, that means an increase in your blood pressure. Hyperviscosity, meaning the blood is thicker than what it should be, so it's harder to move. Qualitative platelet abnormalities, and atherosclerosis, which means that there is a buildup of plaque and such inside the veins, or the arteries rather. Venous thrombosis is associated with slow blood flow. Something has activated coagulation, an impairment of the fibrinolytic system, and some sort of deficiency of the physiologic inhibitors. Other issues that can contribute to the pathophysiology of a thrombosis would be vascular injury due to toxic effect of chemotherapy, platelet abnormalities, coagulation abnormalities, fibrinolytic defects, and deficiencies or defect of the coagulation inhibitors. When it comes to the vascular injury, how everything works in this process plays an important role in the arterial thrombosis because it initiates the platelet adhesion, and once those platelets release their granules, which we talked about in another lecture, it causes the platelet aggregation, so the platelets rush to that area and then they have the plug formation. Then the damaged endothelial cells will release the tissue factor, then the fibrin clot is formed, and then it's going to stabilize that platelet plug. So the platelet is the main component of the arterial thrombosis. Aggregation occurs from the interaction between the injured vessels and the platelets. So in normal hemostasis, the antiplatelet activities prevent excess platelet activity. In disease state, excess platelet activation can cause exacerbation of thrombotic episodes, meaning the disease state is activating more of the platelets, so it causes more potential for some sort of thrombotic or clotting episode. Risk factors that are associated with thrombophilia, meaning an increased amount of clot formation. Physical risk factors can be age, immobilization, meaning you're not able to get up and move around, maybe you're bedridden. Pregnancy, smoking, oral contraceptive use, and hormone replacement therapy. Acquired risk factors are cancer, liver disease, surgery, or DIC. Inherited risk factors would be genetic mutations that result in a deficiency or a defect in naturally occurring inhibitors. Naturally occurring inhibitors are plasma proteins, and they're going to interfere with the clotting factors. They prevent the thrombin formation and thrombosis, so they prevent the blood clot from forming. Naturally occurring inhibitors are antithrombin, heparin cofactor 2, protein C and S. So antithrombin, one of the naturally occurring inhibitors, is made in the liver. It neutralizes the activities of the thrombin 2A, as well as 9A, 10A, 11A, and 12A. The inhibitory action of the antithrombin is increased when it binds to heparin, and an antithrombin deficiency is associated with thrombosis, meaning if you're deficient in this inhibitor, it's directly correlating with having clotting issues. Another naturally occurring inhibitor is the heparin cofactor 2. It's a coagulation inhibitor. It acts against the thrombin. It's heparin dependent, and heparin cofactor deficiency alone is not associated with thrombosis. So you can have this be deficient in this particular inhibitor, but not necessarily have a clotting issue. Protein C is vitamin K dependent. It's also made in the liver. It circulates in zymogen form and then activated by thrombin, the thrombomodulin complex, to a serine protease. It inactivates factors 5A and 8A to stop clotting. We also have vitamin S, which is vitamin K dependent, just as vitamin C. It's also produced in the liver and the endothelium and megakaryocytes, which we've talked about previously. Cofactor for protein C, and it inactivates factors 5A and 8A. Inherited thromboses are associated with decreased levels of coagulation inhibitors, such as antithrombin, heparin cofactor 2, protein C, protein S, clotting factors such as factor 12, prekallikrein, and Fitzgerald factor. An inherited thrombotic disorder is antithrombin deficiency. Type 1 is a quantitative disorder, quantitative meaning number, the amount, and there's a reduction in the concentration of the antithrombin. Then you also have type 2, which is a qualitative disorder. It means the quality or the proficiency, where the concentration of antithrombin is normal, but it functions abnormally. Antithrombin deficiency is associated with recurrent venous thrombosis. The thrombotic event may be primary or may be followed by another factor such as pregnancy or surgery. There's also acquired antithrombin deficiency, and this may be correlated with DIC, liver disease, nephrotic syndrome, which are symptoms that are due to kidney damage, and oral contraceptives. Another inherited thrombotic disorder is heparin cofactor 2 deficiency. It's inherited as an autosomal dominant trait. It's heparin dependent factor whose inhibitory effect is primarily against thrombin. The heparin cofactor deficiency alone is not necessarily associated with thrombosis. Protein C deficiency is an inherited thrombotic disorder. We have type 1, which is a quantitative deficiency. It's associated with the reduction in immunologic and functional activity of the protein C. Type 2 is qualitative, a qualitative deficiency where you have a normal amount of abnormal protein and most mutations are missense. Common complications of protein C deficiency are venous thromboembolism, or VTE. This means that it is a DVT, which is a deep vein thrombosis, and a PE, a pulmonary embolism, which is when a clot travels to the lung. So it encompasses both of those. Arterial thrombosis, neonatal purpura fulminans, warfarin-induced skin necrosis. It may also be linked with vitamin K deficiency, liver disease, or warfarin therapy. Another inherited thrombotic disorder is protein S deficiency. That is inherited autosomal dominant. You have type 1, which is a quantitative disorder where total protein S, free protein S, and protein S activity levels are reduced to about 50% of their normal value. Type 2 is a qualitative disorder where only protein S activity level is reduced. Type 3, free protein S and protein S activity is reduced. Most patients that have protein S deficiency experience venous thrombosis. Acquired protein S deficiency may be correlated with vitamin K deficiency, liver disease, or DIC. Activated protein C resistance, or APCR, is another type of inherited thrombotic disorder. It's autosomal dominant. It's caused by a single gene mutation of factor V. In normal conditions, factors 5A are inactivated by APC or activated protein C. In factor V leading, factors 5A are resistant to APC. So thrombotic complications that are associated with factor V leading are VTE, recurrent miscarriage, and MI, which is myocardial infarction, otherwise known as a heart attack. Laboratory diagnosis for activated protein C resistance may be evaluated by coagulation assays. The inhibition of factor Va by activated protein C, which will cause a prolonged PTT. The APTTT is performed on patient plasma and without the APC. Then the results are expressed in ratio, so the patient's PTT plus the APC and the patient's PTT minus the APC. Plasma from patients with activated protein C resistant have a lower ratio than the reference ranges established for normal patients. So reference ranges may vary, but a range of less than 2 is diagnostic. A DNA test can be used to confirm the specific point mutation in patients with factor V leading. Prothrombin mutations can be caused by a single point mutation. It is an autosomal dominant disorder. It causes an increase in concentration of plasma prothrombin. The risk of VTE increases as the plasma prothrombin level increases to greater than 115 international units per deciliter. Thrombotic episodes can develop early, before the age of 40. Other inherited thrombotic disorders are factor 12, prekallikrein, and Fitzgerald deficiencies. Patients will have a prolonged PTT but no bleeding problem. Factor 12 plays a major role in the activation of plasminogen into plasmin. Factor 12 deficiency have an impaired fibrinolysis and are prone to thrombosis. Dysfibrinogenemia is an abnormality of fibrinogen with variable clinical presentation. Some patients show arterial or venous thrombosis or bleeding. Other inherited thrombotic disorders are tissue factor pathway inhibitor deficiency. TFPI plays a role in prevention of clot formation, and it's associated with thromboembolic disorder. Hyperhomocystinemia is inherited or acquired. They have increased levels of homocysteine in the blood that are reported to be risk factors for such things as atherosclerosis, arterial, and venous thrombosis. Acquired thrombotic disorders may be associated with underlying disease such as cancer, surgery, liver disease, nephrotic syndrome, DIC, pregnancy, vasculitis, and drugs. The most common cause of acquired thrombotic disorders are antiphospholipid or APL syndrome and heparin-induced thrombocytopenia or HIT. We also have antiphospholipid syndrome or lupus anticoagulant, where patients produce antibodies to phospholipids, prothrombin, or apolipoprotein or APO. Clinical manifestations of a phospholipid antibody include thrombosis and fetal loss. Thrombotic episodes can be venous and arterial thrombosis, as well as thromboembolism. This usually occurs between the ages of 35 and 45. The most common forms of lupus anticoagulant are LA and anticardiolipin or ACA. So you have primary thrombotic manifestation, which means there's an independent autoimmune disorder, as well as secondary thrombotic manifestation due to systemic lupus erythematosus. So a patient with APO antibodies may present with thrombosis and fetal loss. Laboratory assays for antiphospholipid antibodies are where the APTT is prolonged, dilute Russell Viper venom test is prolonged, phospholipid neutralization test, and you also have mixing studies. So in the presence of the LA or the lupus anticoagulant, the mixing study does not correct and the PTT remains prolonged. The International Society of Hemostasis and Thrombosis has recommended 4 different criteria for LA or lupus anticoagulant to determine a diagnosis. Prolongation of a phospholipid-dependent clotting test, evidence for the presence of an inhibitor or a mixing study, evidence that the inhibitor is directed against the phospholipids, so some sort of confirmatory test, and lack of any other specific inhibitor. Heparin-induced thrombocytopenia, or HIT, is an immune-mediated complication associated with heparin therapy. Antibodies produced against the heparin platelet factor 4 complex that causes platelet activation. It usually will develop between 5 to 14 days after the heparin therapy has begun. It may cause thrombocytopenia, heparin-induced skin lesions, and heparin resistance. A good indication that HIT is occurring should be suspected is if the platelet count decreases to less than 50% of the baseline value after 5 days of the heparin treatment has begun. Functional assays are immunoassays that help with the laboratory diagnosis of heparin-induced thrombocytopenia. They measure platelet activation or aggregation in the presence of HIT serum or heparin. They look at heparin-induced platelet aggregation, heparin-induced platelet adenosine triphosphate, or ATP release, which is the Lumia aggregometry testing. We also have the 14C serotonin release assay, which is an enzyme immunoassay. There is platelet microparticle formation, which is a flow cytometry methodology. And there's also heparin platelet factor 4 antibodies, and that's detected by ELISA. Patients who do not have a positive family history of thrombophilia should be tested for the acquired form of thrombotic disorders, which could be tied to malignancy, myeloproliferative disorders, and antiphospholipid antibodies. Assays should not be performed when the patient is on therapy because it will affect the results. So the medication would need to be withheld during the time that the testing will occur. Acute venous thromboembolism shows an increased level of D-dimers and fibrin degradation products, and functional tests are preferred over the immunological assays as far as being used as a diagnostic tool. There are different types of drug therapies that can be used. You have antiplatelet drugs. Those inhibit platelet activation and aggregation. It's the most effective in treating arterial disease. Anticoagulant drugs, which inhibit thrombin and fibrin. It's used to treat thromboembolic disorders. There are alternate anticoagulant drugs that can be used to prevent ischemic strokes, which is when there is a clot in an artery that can block the blood flow to the brain. And there are thrombolytic drugs, and those are used to break down a clot if the clot is already formed. Aspirin is an antiplatelet drug, and it irreversibly affects the platelet function. It inhibits the cyclooxygenase enzyme or COX enzyme. It indirectly inhibits the formation of thromboxane A2 or TXA2, a potent platelet activating substance that's released from the platelets. It's effective against treatment against angina, which means chest pain, acute myocardial infarction, which is an acute heart attack, transient ischemic attack, stroke, arterial fibrillation, meaning that there is an irregular heartbeat or heart pattern that's occurring in patients who have prosthetic heart valves. There are other antiplatelet drugs that can be used alone or in combination with aspirin. Some of those drugs are Plavix. You might be familiar with that one. Effient or Brilinta. There are antiplatelet drugs that are used for acute coronary conditions such as Intelglurin, RioPro, and Aggrastat. I'm not going to pronounce the generic name. I'm just going with the brand name. It's easier to pronounce. We also have unfractionated heparin therapy, and this helps prevent clots. It accelerates or disables the inactivation of coagulation factors of 12A, 11A, 9A, thrombin, and 10A. It must have antithrombin to be able to work. It also requires laboratory monitoring, so such tests like PTT, a platelet count, or an anti-F10A assay, which is the most effective in monitoring the heparin therapy. So the anti-factor 10A activity assay is a colorimetric assay that measures the free factor 10A in a sample after heparin neutralizes a fixed concentration of factor 10A and the thrombin. The amount of free 10A is inversely proportional to the heparin concentration. The concentration of heparin is determined by inhibiting factor 10A by antithrombin. There's also low molecular weight heparin therapy, and this is administered subcutaneously, meaning right below the skin, not into the muscle, once or twice daily based upon the patient's body weight. There's no monitoring that's required except in patients with kidney disease, children, and pregnant women using the anti-factor 10A assay. It has a higher inhibitory effect on factor 10A. The low molecular weight does. It's used as a short-term replacement for Coumadin in patients who require surgery. So it's an alternative. So we have Coumadin or warfarin therapy. That is going to be administered orally. It's a long-term anticoagulant. It inhibits vitamin K dependent coagulation factors. So that's 2, 7, 9, and 10. Warfarin is a Coumadin derivative. It's prescribed to prevent thrombosis after trauma or surgery, or to prevent strokes in patients who have atrial fibrillation, which is an irregular heartbeat. And when that irregular pattern of heartbeat occurs, there's the possibility that blood will pull around the heart, and with it pulling around the heart, then you are in danger of the blood clotting in that area. Warfarin is going to be monitored by the PT-INR standardized PT test that we talked about previously, and the most common side effect of using the warfarin therapy is bleeding. For patients with HIT or cannot be treated with Coumadin, the unfractionated heparin, or the low molecular weight heparin, you have direct thrombin inhibitors. Some of those are Angiomax, argotrobin, which affects the PT, the PTT, and activated clotting time. Dabigatran, which prolongs the TT, the PTT, and the ACT. You can also use factor 10A inhibitors subcutaneously. Again, that's meaning that it's injected right below the skin. It's not into the muscle. You have Arixtra, so that's going to be used for surgical prophylaxis and treatment of DVT or deep vein thrombosis, and PE, which is pulmonary embolism. There are also oral factor A inhibitors such as Xarelto, which is used in patients with PE or without DVT. You can also use Eliquis, and that's going to use in the prevention of ischemic stroke, which is a blockage in the artery that will block blood flow to the brain, and atrial fibrillation. My father's actually on this medication. He was recently diagnosed with AFib secondary to other conditions. So if you hear the term AFib, that is atrial fibrillation, and that is one that's used quite often. I've talked to other students and other people whose parents are taking the Eliquis. So thrombolytic drugs are used in acute arterial thrombosis for immediate thrombolysis, meaning a breakup of that clot within 3 to 4 hours after onset of the symptoms. There's restoration after there's been restoration of the vascular integrity. It's to prevent any type of tissue or organ damage. The TPA is going to bind to the fibrin degradation products. It activates the plasmin, and it can cleave fibrinogen with a lesser frequency and severity. Urokinase can be used for the treatment of venous thromboembolism, myocardial infarction, thrombolysis of clotted catheters. Typically, bleeding is the most common complication. Therapy isn't monitored. However, screening tests such as the PT, PTT, and TT, as well as the fibrinogen and platelet count, may be helpful in predicting the high-risk bleeding.